Good morning, everybody. It's been a pleasure for me to extend a hearty welcome to you all to the APELS first lower GI hybrid training program. So far, we received registration of this webinar, almost 400 something registrants, and that include doctors, nurses, and medical professionals. As an academic group, APELS pushes the frontier in the field of endoscopy, laparoscopic surgery in the past 6 years, providing a platform for professionals of the field all over the world to share the up-to-date information and innovative ideas through our physical training workshop and virtual events. This hybrid event capitalizes our strength and realize our commitment to Endo-Lap professionals, to cultivate an intensive learning culture and enhance professional competence in Endo-Lap surgery to meet the ever-changing challenges in today's clinical area. Before we carry on with this event, I will take my appreciation to the course director of this program, Professor Simon Ng, who have been making extremely great effort to organize the high standard and pioneering course, the lower GI Endo-Lap module. The first part of full-day training program is 2-hour-long lecture. We capture the absence of our legendary workshop with the presence of 11 faculties, and they will be introduced you in subsequent lectures. The second part of the program involves closed group endoscopic and laparoscopic hands-on training. Our faculties are nominated total of 17 doctors from selected countries, interact through Zoom platform while performing endoscopy and laparoscopic hands-on training. This innovative training component integrate practical learning with virtual mentoring that aims to facilitate knowledge and skill exchange between countries for the development of Endo-Lap surgery. It is invite-only session. If you are interested in coming hands-on session with us, please fill out the survey after the event with your contact information. We will keep you informed of our next round of hybrid training in the Asia-Pacific region. As the chairman of APELS, I look forward to rapid growth of the society and wholeheartedly commit to educate, train, innovate in every aspect of Endo-Lap surgery. Once again, I welcome you all and sincerely hope that you will enjoy the program. I wish the hybrid training program enlighten us all and provide us with practical approaches to deal with the everyday challenges in our work field, particularly in the current COVID situation. But hopefully, I look forward to see you all in the coming training workshop, both online and in person. Thank you.
Thank you, Professor Michael Lee, for the welcome. Good morning, everyone.
So, Chairman, will you get the program kicked off? The first moderator is Professor Lee Suk Lee and Professor Vitoon from Thailand.
Okay. Thank you. Suk Lee, I'm going to have a little introduction to the course program. So thank you, Professor Michael Lee, for the welcome address. So once again, good morning, everyone. I am Simon Ng from the Chinese University of Hong Kong. Once again, welcome to the APELS Lower GI Endo-Lap Hybrid Module. Now, it has been a while since we last organized the lower GI training course. APELS training course usually has two unique features. One is we'll teach you both endoscopic and also laparoscopic skills. And second, we have hands-on workshop with either PICS or cadaveric models. But because of the COVID pandemic, all the hands-on workshops have been suspended. Knowing the importance of hands-on workshop to trainees, we have been thinking of ways to bring back all these hands-on workshops in a safe manner. And finally, we came up with this idea of organizing a hybrid module. That is, webinar in the morning for everyone, and in the afternoon, several selected units with animal training facilities will conduct hands-on workshop for a small group of local trainees at the same time, and all the units will be connected by internet. Now, this is a pilot trial. We don't know whether it will work or not. So we'll welcome any feedback and suggestions from all of you. Now, for the webinar this morning, it is mainly a basic course targeting those surgeons who are at the beginning of the learning curve in doing laparoscopic colorectal surgery. Now, in the program, we have included topics that are essential for you to overcome your learning curve. And these include anatomy, port placement and instrumentation, step-by-step description of different colorectal procedures, and troubleshooting. Of course, there will be lectures on colonoscopy and hybrid Endo-Lap colorectal surgery. Now, we have invited a world-class faculty from Australia, Hong Kong, Korea, Philippines, and Thailand to share the wonderful experience with you. And I hope you will find the program educational and academically rewarding and useful to your clinical practice. Now, there will be 2 Q&A sessions, and please don't hesitate to ask the speakers if you have any questions, or you can use the chat window of the Zoom to type your messages and questions. Now, before we begin, may I remind all the speakers that because we have a very packed program, please keep your time. And without further ado, may I invite the moderators of the first session, Professor Suk Lee from Korea, and also Professor Vitoon from Thailand, to start the program. Thank you very much, and please enjoy.
Thank you very much, Simon Ng. I'm Suk Lee from Seoul, South Korea. I will moderate the first session with Professor Vitoon from Thailand. For the easiness of the program running, I will introduce first 3 speakers to you, and then Professor Vitoon will introduce the rest of the 3 speakers, I think. Let me introduce the first speaker of the session, Professor Michael Lee. He is the current chairman of the APELS, and then there is no need to introduce him briefly, but now he is the honorary consultant of the director of the minimally invasive and robotic surgery development Hong Kong sanatorium in Hong Kong, and then he had a lot of contribution to the society. So I will skip the introduction of him, and he will talk about today the Endo-Lap OR. Professor Michael Lee, please.
Thank you very much, Sukhan, for the introduction. I've shared my talk. Have you guys seen the talk or not? Can you see my talk?
Yes. Yes. From now on, yes.
Good.
I can see your talk.
All right. So my topic this morning is to talk about Endo-Lap OR. So crucial to APELS Endo-Lap mission. Minimal access surgery, well, it's reducing the size of incision has been a dream of surgeons for thousands of years. And then, as remarked by Ronald Marvick, surgical technique will more or less be combined techniques in the future. So, if you look at minimal access surgery, there are 2 different approaches. One is endoscopic surgery, the other one is laparoscopic surgery. As you all know, with endoscopy or endoluminal surgery, we eradicate the need for ulcer surgery for bleeding ulcers, polyps and taken away by ESD, EMR, and of course, common bile duct stones can be dealt with ERCP. Most important of all, in the last 10, 15 years, we have developed technique, endoscopic decompression of left-sided obstruction of the colon. In effect, as early as 2002, the first randomized trial was performed by us in Hong Kong, showing colonic stenting can temporarily relieve acute obstruction, allow patients to enjoy benefit of MIS later, avoid the creation of permanent stoma. And this has now become standard practice in our area. So why Endo-Lap OR? Well, despite advances in maturity in the surgical technique, both lap surgery and endoscopic approach have their own limitation. So what if we have them perform together to get a complementary role? So endoscopy, laparoscopic surgery combined together for our patient, and we developed idea endo-lap approach to GI disease. Now, this is traditional open surgery, as you can see, some 30 years ago. And then we now move on, not just having a room to do ordinary OR, but open OR, but we're moving to endo-lap era. This is what an endo-lap theater looks like well, this picture was taken 20 years ago, of course. This is what I'm talking about, the current OR facilities, endo-lap OR. We developed the first endo-lap OR in Hong Kong in January 2005. This is the video concept. Project began. Theater to design both endoscopy, laparoscopic surgery, performing on the same patient with all the available instrumentation in the same facilities. This all came into being, resulting in the last slide that you saw. So what the benefit? Well, availability of equipment for both minimally invasive surgery and endoscopy, easier operating theater setup. No need to wheel in and out bulky equipment, no need equipment connection or reconnection because one plug technique. Facilitate theater setup, easier to clean up, improve patient turnover. In fact, we did a study in back then in 2006 showing the advantages, as you can see here, from using endo-lap OR. So, in conclusion, the endo-lap OR is easier for surgeon, simpler for the operating room staff, safer and better for patient. Of course, further on from year 2000, we have added the robot. And that came about with the robotic endo-lap OR, which I won't show the video because it's, the advantage of the robot is the 3D images for operating has now become a very essential part of our laparoscopic surgery equipment. This is the 3D robotic endo-lap OR in action. So this came into being in 2009. All these are to show us how we can use these facilities. So integrating operating theater for the future, the goal is to provide the best environment for surgeon and the operating team. Working conditions are improved without compensation of safety, efficiency, and comfort. And the ultimate aim is to deliver better service to our patient to get better outcome. My message is continue to innovate, develop, improve, and discover new frontiers to improve patient care. Thank you very much for your attention.
Thank you very much. In this session, the Q&A will be placed at the bottom of the session. So let me move to the second speaker. It's a pleasure to introduce Dr. Karen Tung. She's a specialist in Yan Chai Hospital, Hong Kong, and she is the council member of the Hong Kong Society for Coloproctology. Today, she will talk about the laparoscopic colorectal surgery, the current evidence. Please welcome Dr. Karen Tung.
Good morning, everyone. Thank you for the kind introduction, and also thank you for APELS invitation today. So, good morning. I will talk about laparoscopic colorectal surgery, the current evidence. Since the first laparoscopic assisted colectomy performed in 1991, colorectal surgery have revolutionized and entered into the MIS era. So over the last few decades, there were several larger scale RCT performed on laparoscopic colectomy, such as the COLOR or the CASIC trial. So all of them have confirmed definite short-term benefits as well as comparable oncological outcome of laparoscopic colectomy. And laparoscopic colectomy has already become the mainstay of treatment for colon cancer in many of the surgical units around the world. So how about rectal cancer surgery? So the result of the first RCT comparing laparoscopic and open rectal surgery, the CASIC trial, have already demonstrated that no significant difference was observed in terms of the morbidity, mortality, and oncological outcomes. But however, there were two important concerns raised at that time. Firstly is much higher CRM positivity of laparoscopic rectal surgery, which is 12% as compared to 4%. And although the result is not statistically significant and translate into poorer oncological outcome. And secondly, is a very high conversion rate in the laparoscopic group, up to 34%. But as times go by with increasing experience and also improvement in surgical techniques and also instrument, and also with the introduction of the new adjuvant chemo-RT, the result of the laparoscopic TME have demonstrated much better results nowadays. So this is a recent meta-analysis published in 2019 involving 14 RCT comparing laparoscopic and open rectal surgery. So the laparoscopic group have a much better short-term outcomes, such as the wound infection, hospital stay, return of bowel function, return to the normal diet, analgesic usage than the open group. And the laparoscopic group was also found to be non-inferior to the open group in terms of the oncological outcomes, such as the positive CRM margins, the incomplete pain of mesorectal excision, or the number of lymph node harvests. So the robot is definitely one of the major developments in the last century. And the first reported case of robotic-assisted colectomy was reported in 2002 on 2 cases of diverticular disease. So does the robot offer additional advantage on colectomy? So this is a study reported on robotic versus laparoscopic colectomy. And the results have shown that robotic colectomy results in similar perioperative outcomes as compared to laparoscopic colectomy, but this is associated with a much longer operation time. The robotic group takes about 30 minutes longer than the laparoscopic group. And what's more important is, of course, the much higher hospital charge in using the robot. So it seems that it is not worthwhile to use the robot to work on colonic cancer. But in contrary, the rectal cancer occurs deep in the pelvis, and as the tissue dissections go downward, a more secure field of vision is required, and tissue manipulation using the laparoscopic instrument also become much more difficult. So robots can definitely overcome many of these limitations of laparoscopic surgery. So the ROLLER trial is the landmark paper of robotic TME. It is a multi-center RCT involving more than 400 patients. And the primary study outcome of the ROLLER trial is the conversion rate to open. And the conversion rate of the robotic group is 8.1% as compared to 12% in the laparoscopic group. But the result does not reach statistical significance. But by doing subgroup analysis, the male patient group, the conversion rate of robot is 8.7% as compared to 16%, and the result is statistical significant. This is mainly because the male pelvis is much narrower than the female patient, and if we affect the technical difficulty of laparoscopic surgery in the narrow pelvis can be overcome by the robots. So as for the secondary outcomes, such as the intra-op complication, post-op complication, the 30-day mortality, the functional outcome, all did not show any statistical significance between the two groups. So this is another recent meta-analysis comparing robot and laparoscopic TME involving 25 studies. So again, significantly more patients in the study with high BMI, tumor with shorter distance from the anal verge, post-neoadjuvant treatment choose robots to perform the TME. And the conversion rate was also significantly lower in the robotic group. And no significant difference was observed in the short-term outcomes, the pathological and oncological outcomes. So Professor Lacy have developed a novel approach of transanal TME in 2010. So it involved laparoscopic dissection and also transanal endoscopic dissection. So this approach has the advantages of adequate distal margin is ensured and no double firing is required. So many of the study nowadays has already revealed the feasibility of this novel approach. But recently there were two main controversy about reported on this new approach. Firstly is obviously is post-operative complication, because dissection in the wrong plane may result in severe complication like urethral injury. And Professor Lacy have reported a series of 34 urethral, 2 ureteric and 3 bladder injury within 7 years period of time. And although many of these cases occurred early in the early series, but it reflects the technical difficulty of this new approach, and so a more technical or more anatomical expertise required to perform this new approach in order to achieve a better surgical outcome. So second controversy is about its oncological outcome. So a recent study from Norway 2 years ago reported an early and multifocal pattern of local recurrence after the TATME. The local recurrence rate was reported to be 9.5% as compared to 3.4% in the laparoscopic group. Some of the surgeons hypothesized that it is due to the insufficiency during the transanal dissection can result in tumor cell dissemination in pelvis or the distal rectal remnant. So this is a meta-analysis comparing TATME and laparoscopic TME involving 18 comparative studies. No difference was observed in the intraoperative complication, postoperative complication, and stomatic leakage, surgical site infection, and operation time. And TATME was associated with much better pathological outcomes, such as high number of outlook resection, high number of harvest limb lock. And also because of the Norway studies, Professor Lacy has done another multi-center comparative analysis, mainly focusing on the oncological outcome between TATME and laparoscopic TME. So instead of impairing the oncological outcome, TATME can improve the local regional recurrence and also the disease-free survival rate because of a better quality of the TME specimen. So finally, recent hot topic must be the concept of CME for right-sided colonic cancer. So this technique aims at mobilization of the mesocolon from the parietal plane and tie the root of the superior artery. So it has two main advantages. Firstly is that it can increase the lymph node harvest and improve the oncological outcome. And also because of maximize the lymph node number, you can have adequate staging of disease so that the patient can receive the most appropriate adjuvant treatment. So this is a study comparing laparoscopic CME and laparoscopic formal white hemicolectomy. So no difference was observed in terms of the conversion rate, the postoperative complication, reoperation, readmission, and mortality rate. So obviously the number of lymph node harvests must be high in the CME group, which is 22 versus 19 lymph node. And there were no way of inadequate sampling in the CME group. So another study on the oncological outcome after laparoscopic CME. And you saw, once again, you saw that the CME group had a high number of lymph node harvests, and this transferred to a better oncological outcome. The CME group had a higher 3 years overall survival rate. So this is the end of my presentation. This is just a very brief review of the MIS colorectal surgery. And I think as a surgeon, we need to be innovative and to develop and discover new techniques to improve the surgical outcomes. So thank you very much.
Thank you very much, Dr. Tung. Let me proceed to the third speaker. The third speaker is the Dr. Peadar Waters from Australia. Dr. Waters is the consultant of the general and colorectal surgeon. He also is a surgical lead for the ERAS program, Peter MacCallum Cancer Center, Melbourne, Australia. He received many awards and scholarship grants from many countries. Today, he will talk about the essential anatomy for laparoscopic colorectal surgery. Please, Dr. Peadar Waters, please.
Thank you. Can you see my slides okay? Thank you. Can you visualize my slides okay?
Yes, we can see your slide. So please talk a little bit louder.
Okay. I'd like to thank the committee for inviting me today to speak. I'll be talking about the essential anatomy for laparoscopic colorectal surgical procedures. This will be done in two parts. First looking at the colon and then looking at the rectum and pelvis, particularly pertaining to the arterial supply, venous supply, lymphatic drainage, and nerves. And I'll also be discussing the topographical anatomy at laparoscopy, and then discussing briefly looking at anatomical dangers related to resection. Very briefly, just on the abdominal wall anatomy, you always have to be mindful of the inferior epigastric artery, which runs through the rectus abdominis muscle. So therefore, you've got to be at least 7 centimeters lateral to the midline or umbilicus to avoid danger to this vessel. The arterial supply of the colon comes directly from the SMA and the IMA. The SMA branches of the ileocolic, occasionally the right colic, and the right branch, the middle colic, supply the right colon. The middle colic supplying the transverse colon, and the IMA directly off the aorta supplying the left colon and the rectum. The rectum is supplied by the superior rectal off the IMA, middle rectum off the inferior epigastric, and inferior rectal off the pudendal artery. The venous supply of the colon mirrors that of the arterial supply, and you have to be mindful of the venous supply when you're particularly performing CME with CVL. The lymphatic drainage of the colon is very important to note. There are different layers of drainage lymph nodes, predominantly the epiploic, which is lining of the gut wall, the paracolic, which is on the medial side of the mesentery, intermediate draining nodes on the main branches, such as the ileocolic or the IMA, and terminal nodes, which is in the mesenteric root. These nodes typically follow the arterial supply, so it's incredibly important to know the arterial supply to perform a high ligation to resect all lymph nodes involved. The nerve supply of the colon is both parasympathetic and sympathetic. The hind gut and the midgut are supplied by the parasympathetic nervous system by the vagus nerve and the nervii urgentes. The sympathetic nervous system of the midgut is T11 to L1, and the hindgut L1 to L2. So briefly, just touching base on the different types of surgeries for the right colon and an extended right hemicolectomy. The main vascular pedicle here to dissect during a right hemicolectomy is the ileocolic pedicle, and this allows access into the retroperitoneal plane. One of the first structures you meet here on opening the mesocolon from the caudate to the cephalad would be the duodenum, and this has to be protected both medially and inferiorly. As you develop the ileocolic planes, you can see here in this picture the ileocolic vein coming off the SMV and the ileocolic artery, and directly below this will become the duodenum. So care has to be taken here with cauterization. Next, this is a brief description looking here at laparoscopic photos looking at the ileocolic artery and ileocolic vein arising from the SMA and the SMV in relation to the pancreas and duodenum. And this is during your medial to lateral dissection for right hemicolectomy. Variations do exist in SMV and SMA anatomy, and care must be taken when you're doing a CME and central vascular ligation for advanced rectal cancers. So this is just a brief video. As the dissection is undertaken, we can see here the development of the ileocolic pedicle allows dissection in the retroperitoneal plane. And very briefly here, you'll see development of the duodenum, which has to be protected. Again, this is high ligation of the pedicle off the level of the inferior epigastric, off the SMA and the SMV, with protection of the pancreas and the duodenum. And this is ligating of the colic arteries coming off the middle colic, the right branch. And this is breaking through the mesocolon into the supracolic compartment where the level of the gallbladder is. As you develop the mesocolon plane, you will come across the gallbladder and the liver. You have to take care also of the right ureter as you develop the lateral dissection. And this is easy in a skinny patient, but sometimes can be difficult in a obese patient or patients with Crohn's disease. So care must be taken during lateral dissection of your right colon. During an extended right hemicolectomy, access into the lesser sac is important, and you will see here the pancreas lying below and the posterior part of the stomach as you dissect towards the splenic flexure. This here is a picture showing the transverse colon above, the duodenum below, and the pancreas as you dissect in that lesser sac plane. And again, a diagrammatical representation, what you're trying to do is ligate the origin down at the base of the mesocolon, the transverse colon, and resect the branches of the middle colic artery and vein. In left colectomy, I generally begin with a IMV first approach, where you raise the IMV, and this is it here, and approach the retroperitoneum in that plane. This here is some pictures showing ligation of the IMV as you go along the retroperitoneal plane, which is important to protect, along gyrotis fascia. Part of the procedure also is ligation of the left colic artery off the IMA. And it's important to note the anatomy of the IMA, where the left colic artery takes off, because this will inform your oncological resection. Very briefly onto the rectum and sigmoid. The rectum is 15 centimeters long. It begins at the third sacral vertebrae and ends in front of the coccyx. It is fixed posteriorly by Walder's fascia and anteriorly by D'Anvillier's fascia. And anatomically, it's important to note where your tumor lies at endoscopy in relation to your valves of Houston, as these are constant. And these divide the rectum into lower, mid, and upper rectum. The arterial supply I previously mentioned is from the superior rectal artery via the IMA, the middle rectal artery via the internal iliac, and the inferior rectal artery via the pudendal. And the venous supply matches this. The lymphatic drainage of the rectum is very important, and the upper and mid rectal tumors drain via the pararectal and inferior mesenteric lymph nodes, and the lower rectum drains via the sacral group of lymph nodes and the internal iliac. The nerve supply of the rectum and pelvis, the sympathetic system is supplied by L1 to L3 and the parasympathetic by S2 to S4. And it's important to preserve these nerves during dissection to prevent issues with bladder function, rectal function, and impotence. Here is a diagrammatical picture showing you the presence of Walder's fascia in the presacral plane and D'Anvillier's fascia anteriorly with the seminal vesicles, and the hypogastric nerves and nervi urgentes coming off the sacral plexus. At laparoscopy in the pelvis, you'll see the rectovesical pouch, which can vary depending on the sex of the patient and how broad their pelvis is. The IMA is the main pedicle to dissect during rectal cancer dissection, and this is done by identifying the sacral promontory and dissecting under the vascular supply. As you dissect the presacral fascia, you will come from a medial to lateral approach. You will see the ureter, which must be protected during your dissection. As you do your lateral dissection along Toll's fascia, again, the ureter on the left-hand side will come into visualization, and this must be protected. During your lateral pelvic dissection, the key components anatomically to protect again are the ureters, which you can see running down laterally, and the major vessel supply to the left pelvic sidewall. And lastly, this is just a diagrammatical representation of your dissection line along the mesorectum to resect that nodal package along with the rectum and protect these anterior structures such as seminal vesicles in males and the prostate, and vagina in females. Thank you very much.
Thank you. The following session will be moderated by Professor Vitoon from Thailand.
Thank you, Professor Lee. Let's start the next speaker, Professor Craig Lynch. He is a colorectal surgeon in Edward Hospital, Melbourne, and also Sydney Adventist Hospital in Australia. He's also the board member of APELS. Today, he's gonna give a talk about the trocar placement, instrumentation, and NG device. Please, Professor Craig Lynch.
Thanks, Vitoon. That's very good. Can you see those slides? Good.
Yes, please.
Okay. Well, it's a great pleasure to sort of be doing another APELS meeting. I'm sorry we can't do it in person. Hopefully at some point we'll all get together and meet. I'm going to talk a little bit about some of the main points about setting up a laparoscopic case and the instruments and what we should do. You want an easily mobile table. You want the patient well positioned, so either on a beanbag or with the arms securely tucked by the side, so that when you tilt the table, the patient's going to be nice and secure. Especially for left-sided resections, make sure when you start that the perineum is over the end of the table, because if the patient slips up the table during the operation, it's very difficult to access the anus and place a staple gun, and all those things are much more difficult. So planning ahead on that is useful. And put the patient's legs in stirrups or yellowfin stirrups. Now, here's the positioning for a left colectomy. And essentially for a right side, you can turn this around the other way. And not so much really where things are, but to appreciate that you need your assistant or camera holder in a comfortable position with plenty of space next to you. And your nurse needs good access for their instrument trays, and so they can hand you things as well. And you definitely always need a monitor on both sides of the patient. But also thinking about how you're setting up the room, it's how you're setting up the table in relation to a nice, comfortable way of standing. So when you're looking across at the screen, it should be directly across from you at eye level. And the table really needs to be at a comfortable angle so that you're not reaching or you're not straining. Now, part of this means that if you're very tall or your assistant's very tall, that you need to have the bed height that's comfortable for both of you. So if that means getting a step for one of you to stand on, then that's important to plan ahead for, because there's nothing worse than doing a long, complex laparoscopic operation if you haven't optimized your positioning. Now, we usually start by placing a Hassan port, usually subumbilically under direct vision, and securing it. Now, when you've done that and established your pneumoperitoneum, that is the time to start thinking about where you're going to place your ports. Don't think about it beforehand, because when you insufflate an abdomen, all abdomens insufflate differently, and your ports will be in a different place from where you think they're going to be. So the standard setup really for a left colon is 2 ports on the right-hand side of the patient and 1 on the left for your assistant. Now, you need usually to place a stapler in the lower left quadrant, so the lower right quadrant. So that needs to be a 12mm port. All the ports should be lateral to the rectus, but don't go too far lateral, especially with that 12mm port, because if it's too low and too close to the anterior superior iliac spine, you won't be able to get your stapler over the brim of the pelvis and down to the pelvic floor. So think about when you've insufflated the abdomen, staying high enough where you can visualize that that stapler and that instrument will get to the pelvic floor easily. Now, the 5mm port on the left side, which is good for your assistant, is also useful for when you're approaching the splenic flexure, and you can tilt the patient head up and left side up and stand between the patient's legs to mobilize the flexure. And the other thing to remember is if the ports aren't in the right position, then place another port in a better position. It's always better to place a port in better position than struggle with ones that aren't quite right. Now, when we're spacing our ports apart, we always talk about them being a hand's breadth, but even that is sort of variable, and really it comes down to a comfortable position for our hands, and that often relates more to how far apart our shoulders are and where we're wanting to approach across the patient. But we do need to make sure that the ports are far enough apart that we can get good triangulation, which enables the instruments to work most optimally. And think about where you're going to place your ports. Big abdomens like we see here in Australia, we really do get a different port placement than you might expect. And the important thing to remember is when you've insufflated the abdomen, then use the most of the dome of the abdomen and keep the ports relatively high. And that means you can get better reach on your instruments to get to the extreme corners of the abdominal cavity. And then at the end, think about where your extraction site's going to be. Sometimes that can be where your 12mm port is, and then you can remove it and place a protected wound retractor to extract a cancer, so you're not risking seeding the wound with tumour cells. But also it's good to remember. And then at the end of the case, if you want to have another look, you can place a glove over that port, re-insufflate and wash out and check for bleeding. Now, apart from the standard instruments like diathermy or a hook diathermy or scissors, probably the most important thing to think about are bowel graspers, and everyone will have their own choice, but make sure that they don't damage small bowel when you use them. I particularly like these A-track graspers that have got little pads on the end. I partly like them because they've got very comfortable handles that don't give me sore thumbs for long cases. Although their slight disadvantage is they're slightly larger than 5mm, and if you're not careful, they can get stuck in ports. Now, I'm going to talk a bit about energy devices, and essentially delivering energy to blood vessels and tissue means that we can either seal them if it's at a lower level of temperature, or if we deliver higher temperatures, we can actually desiccate and then divide those tissues. One thing that's important in this graph is that it doesn't take much heat to irreversibly damage tissue, and especially if we're touching bowel with energy instruments, we've got to remember to make sure they're not hot. Otherwise, we'll get a problem with late perforations and things like that. So with sealing vessels, we're delivering a lower amount of temperature, and what we're doing is essentially disrupting collagen bonds, making it all a bit of a plastic mess, and then sealing it by squeezing it together. If we deliver more energy, then we destroy the cells and we're able to cut the tissue. So if we modulate the energy, we can actually get good sealing of vessels and tissue and reduce bleeding. So bipolar instruments will desiccate and shrink the cells in a vessel wall and glue the collagen together. The other side of it is ultrasonic instruments. They use friction, and the blade vibrates backwards and forwards very quickly. That creates cavitation and vaporizes cells and produces a bit of steam as well. So a harmonic scalpel is an ultrasonic instrument. So that blade's vibrating backwards and forwards very quickly. With repeated use, it can get very hot, but it's a very good dissector because it can cavitate the tissues and enable you to visualize the planes, especially if the tissue is quite fatty. Now, the other sort of main type is like a ligashore, which is using bipolar energy, but it's also monitoring what's happening to the tissue thousands of times a second as you're delivering that bipolar energy. So When you've got a blood vessel in a ligature and you're delivering bipolar energy, it's modulating the temperature delivered to optimize it for sealing. And when that's optimal and it thinks it's sealed it according to an algorithm, it'll give you feedback in terms of a noise from the generator, and then you can use a blade to cut. And here you can see a nice bleeding vessel. It's going to seal nicely without cutting through. And we can apply the energy 1 or 2 times if we need to. And once it's told us that it's divided, we can cut the vessel. One thing about bipolar energy, it doesn't do well on vessels that have atheroma in it. It works well by sealing collagen, but if there's atheroma in the vessels, it won't seal those vessels as well. So avoid atheromatous vessels when it comes to using a ligature for sealing. But that said, it does a very nice job of sealing mated blood vessels. So bipolars don't make as much smoke, and they probably don't get as hot as an ultrasonic device, but they do act a bit slower. And ultrasonics is quite good because they work quite quickly. They don't really make smoke either. Actually, what we get is steam in the air. But we can also combine the two, and probably in the labs today, you'll be able to use the Thunderbeat, which actually uses both sorts of energy. Now, if we use it to purely seal tissue, that's only bipolar, but we can also use it to seal and cut, and that also delivers a degree of ultrasonics at the same time. So we can use it when we're dividing tissue, much the same way as a harmonic. It's faster to do this than with a ligature, for instance. But again, that blade will get hot given enough time and repeated uses. And because it's got the bipolar element, it's also a very safe way of dividing blood vessels. Again, we can put it on. The feedback the instrument gets as we're delivering energy means we can optimize the sealing. And once it's sealed, we can then cut through the vessel itself. And as an instrument, it can give a very reliable seal on a blood vessel. Now, one thing to remember when we're sealing blood vessels is most of them are rated to a certain diameter. And if you put on your instrument at an angle, you're increasing the diameter of the vessel that you're sealing, and you're increasing the chance that it might fail. So always try and place your instruments perpendicular across large vessels when we're sealing them to improve the result. And again, I want to reiterate that when we use these energy sources, if we use them frequently, they get hotter and we're at high chance of damaging any other structures we might touch. So we have to let them cool or touch them to other instruments or take them out or cool them down somehow, so we don't risk damaging structures that we want to keep safe, like small bowel. So in the lab today, think about 3 things that advanced energy devices actually are there to make things easier, but we've got to be aware of the device. So think about the settings that we're going to put them on, and think about what the settings do to changing our dissection pattern, and always be very aware of thermal injury, which may cause us trouble with complications later. Thank you, Vitoon.
Thank you, Professor Craig. Yeah, very nice presentation. I love your cartoon illustration, right? Let's move on to the next speaker, Dr. Joseph Fuentes. He's a consultant in colorectal surgery and also the chief of section in colorectal surgery in Metro Manila, Philippines. He's going to talk about the right hemicolectomy, how I do it. Please, Dr. Joseph.
Thank you very much. Can you hear me?
Yes, please.
Right. Thank you very much, Professor. Again, good morning from PCAS Manila. No disclosures. So I've been tasked to put together a video outlining the techniques on how I do my right colectomies. But I cannot overemphasize that careful patient selection and perioperative management is just as or even more important than doing the surgery itself. So here's our usual port placement, and it's nothing fancy. It's basically optic port through the umbilicus via the Hasson's technique. And extraction site tend to be at the midline in the majority of cases. So I'll go ahead and jump to the video here, and just a quick one on the conventional laparoscopic right hemicolectomy. So as always, exposure is essential and always starts with good recognition of important landmarks and the critical views and setting yourself up for success. And so my goal essentially is to access that space between the meso and the retroperitoneum and developing that retroperitoneal cage with a combination of blunt and sharp dissection and really actualizing that tunnel with a gauze. And then we'll go ahead ligating the vascular pedicle early. And here are the ileocholic vessels, which are pretty much constant and are quite easy to work with. We then continue with our medial to lateral dissection and kind of sweeping the Herodes fascia down laterally. And just finding that avascular plane. And here's the duodenum. Now putting in the gauze again to actualize that space for future reference. Now, mobilization of the transverse column here. We're going right over the duodenum and incising the lateral attachments and coming around the hepatic flexure. Again, recognizing the gauze that we placed earlier. And further dissection of the transverse mesocholic page and diving into the sulcus ensures adequate mobilization to facilitate specimen extraction and our anastomosis extracorporeally. And here's just showing you how we take the ileal mesentery, again, to facilitate specimen extraction and in our hands, extracorporeal anastomosis. Again, in the interest of time, I will not be talking about the rationale behind doing a D3 lymphadenectomy or central vascular ligation, but I think it's all a matter of time before this becomes standard of care here in our country. So in our hands, again, the medial to lateral approach seems standard and more in line with the principles of the no-touch technique. And this is what we essentially apply regardless of whether we're doing a conventional or so earlier or the caudal to cranial, like in this case, or even whether it's a D2 or D3 lymphadenectomy. So essentially, it's all about developing that mesofascial or retrofascial cleavage plane to really mobilize that shiny meso as an intact inviolate package. So again, the duodenum is the first and important landmark which we encounter early. It has the tendency to creep out during your dissection. So this has to be gently swept down off the mesentery early in your dissection. Again, it's all about that. So this is the first glimpse of the head of the pancreas. And this, in fact, is the first critical view based on the open book model by Stephen Benz, which really ensures a correct dissection between the retroperitoneum and the so-called ileocholic page. So again, it's all about sweeping the duodenum downwards, a combination of blunt and sharp dissection, and finding the right plane. Again, putting that gauze for future reference. So another component of CME, as you know, is the high tie to maximize the vertical lymph node dissection. And the superior mesenteric vein is the key landmark here. And seen here is the V view again from the open book model, which corresponds to the mesentery distal to the ileocholic vessels, just to the right of the SMV as shown here. And here you can see the ileocholic vein now being taken smack to the SMV. Now, here's the ileocholic artery, which is pretty much present 100% of the time off the SMA. So we're going to take that and secure that with hemolocks. And it's just a matter of following the SMB axis as you go cranial. So we're opening the gastrocolic ligament on the left. This will allow you this two-sided approach to transverse meso and the venous confluence of the GCT. And we've clearly opened the lesser sac here and proceed to incising the lateral attachments. Now we're right under the gallbladder here, coming over the hepatic flexure again. So again, if you've done enough retroperitoneal dissection, you've really gotten most of this taken care of. So again, using energy device, take all these peritoneal attachments. Now, dissecting around the middle colic vessels as well as in the GEZT are, in my opinion, the most difficult. And sometimes, instead of using the Matador technique of lifting up the transverse colon and dissecting away, I would sometimes gently pull the transverse colon or meso down to trace the origin of the middle colic vessels. And here we've gotten hold of what looks like the right branch of the middle colic vessels. And again, establishing that sulcus that runs along the inferior border of the pancreas that leads you right to the GCT. You can see the pancreas right there. And again, it's all about dissecting and marrying your dissection, supramesocolic, inframesocolic. So this case is particularly challenging, mainly because of the large lymph nodes, as you can see here. And here's probably the right colic vein that we're taking as well. We have to secure. And finally, the origin of the right branch of the middle colic vessel, ensuring adequate blood supply to the remaining transverse colon. And taking the remaining attachments, I think these are just drainage coming off the GCT, which you also have to secure. And here's the operative field after your central vascular ligation. Now, a much more simpler case following this. So again, you can see on the left side, the critical view number 1 showing the duodenum and the head of the pancreas. We're flipping the page to the ileocolic page to demonstrate the critical view number 2. And once again, the superior mesenteric vein is the key landmark here, which really corresponds to the midline, sometimes opposite the falciform ligament. Here's just showing, so here we're exposing the ileocolic vein now, also being taken at its root. Followed by the ileocolic artery, dissected 360 degrees. Then you have to secure that with hemolocks. And again, it's really all a matter of following that SMV axis all the way up until we reach the back of this so-called symbolic book. And that is where the axis of the gastrocolic trunk is located. So that's the gastrocolic trunk right there. So here's just showing you how we tackle the right branch of the middle colic artery for this particular case by dissecting it inframesocolic and following it towards the base of the transverse mesocolon. So here you can see the possible right branch of the middle colic being isolated. And then we're going to follow that until we can accomplish this so-called critical view again, which shows the origin of the right branch of the middle colic artery, which again really ensures you adequate perfusion of the remaining transverse colon. And then we'll proceed as usual with the transection of the proximal transverse and the mesentery. So again, this is the post-operative field after your central vascular ligation. And again, a specimen has been extracted to a transverse right upper quadrant incision. And the patient was sent home after 2 days. Thank you very much.
Thank you, Joseph, for such a nice video presentation. Because we are a little bit run behind the time, let me introduce the next speaker. He's a famous MIS surgeon, Dr. Alfred Allen Buenafe. He's now the Executive Director of PCAS in Manila, Philippines. He's also the immediate past president of the ELSA and also the editorial board and board committee, the APELS. Is going to talk about the splenic fracture mobilization. Please, Professor Allen.
Thank you, Vitoon. My lecture is about splenic fracture mobilization. I don't have any disclosure. Anyway, splenic fracture mobilization during laparoscopic colon surgery usually can be a challenge for surgeons, especially those who would want to start doing their laparoscopic surgery. Especially anatomically, it's quite difficult for patients to present. In this presentation, the inframesocolic, the supramesocholic approach, and of course, the lateral to medial approaches will be demonstrated and explained. Usually, left-sided malignancies comprise of about 2/3 of all colon malignancies. And in some subset of this patient, actually a majority of that subset of the patient, you would need a splenic flexure mobilization because we don't want any anastomosis with tension. So you need an elongation of that remaining colon after resecting the descending colon or even at the low anterior resections just to have a good anastomosis without any tension. It's quite technically challenging and a very high learning curve to do. This is a study from Jamali that was published in 2008, and it would show you that splenic flexure mobilization or even a splenic flexure resection is one of the most difficult parts in doing your laparoscopic colorectal surgery. And I'll show you why it's quite difficult. So anyway, let's start with the anatomy. If you look on the picture on the right side, it's important to understand the location of the splenic flexure in relation to the different organs near at the fascial planes. You need to understand that right behind your splenic flexure would be your pancreas at the inferior side, your spleen on the lateral side, and the stomach at the superior side. So the root of your transverse mesocolon is on the caudal edge of your pancreatic body and the tail, and of course the mesocolon spreads out from a characteristic fan shape. The figure here on the right side would show you that the dorsal mesentery consists of 2 sheets originally and then becomes 4 sheets. So you have 4 planes that you need to contend with just to be able to incur and to be able to do a splenic flexure mobilization. It forms your omentum between the stomach and the transverse colon. A 3rd sheet of that dorsal mesentery becomes the dorsal wall of your omental bursa, while the 4th sheet of the dorsal mesentery and the ventral leaf of the transverse colon are quite fused. So these are the spaces that you need to contend with and to open up just to be able to bring down that splenic flexure. So it's relevant to know the procedural aspect of your splenic flexure mobilization, consisting of the division of your splenocolic. So your splenocolic is here, your phrenicocolic, your gastrocolic, and your pancreatico-mesocolic ligaments. So the left mesocolon forms the left fascia of your cold fascia. So this is the left fusion of your fascial cold. Going up, you'll see the Tolt's white line of the lateral side. So more often than not, those surgeons who are doing a left-sided colon surgery would know the Tolt's white line. But opening up, especially when you're doing your inferior going up to your superior side, when you're doing your medial to lateral dissection, this one, the left fusion of your fusion of the fascia of the Tolt right after your inferior mesenteric vein is quite difficult to understand. So anatomically, we need to understand the anatomical variations in this area. If you know the anatomical variations, the anatomical position of your splenic flexure, then you'll be able to do a very good splenic flexure mobilization. So just to show you the lateral approach, so this is how we do it. So I think the easiest way to do a splenic flexure mobilization is the lateral approach. We're quite used to it because this is the one that we're doing when we're doing it in the open method. So you line up the Toltz fascia on the lateral side, you open it up, and then identify all the fascial plane or the fusion planes, and then you'll be able to take down. This is now your splenic flexure. So just taking down the mesocolic, splenocolic, then you'll be able to take down this splenic flexure part of your colon. So division of all these attachments can bring down your splenic flexure properly. So just to show you, in the interest of time, I'll move it forward. So this is now your taking down of your gastrocolic ligament, just to be able to bring it down. I'll move this forward in the interest of time. So now we'll be able to identify this is your gastrocolic. Now your pancreas can be seen at the inferior wall. So now you have a complete mobilization of that splenic flexure. So this is now your pancreas. Can you see this one? So this is now your pancreas. Just opening up that area, you'll be able to bring down the whole splenic area. So you have a complete splenic flexure mobilization. So this is how we do it when you do it your lateral approach. I think this is the easiest position, the easiest approach that you can do. The superior approach, especially when you're doing your transverse colectomy, this is a video that we do for a transverse colectomy with superior to lateral mobilization. Again, the position of the patient is the same position that we do every time we do a colorectal procedure. So displacement of your omentum superiorly, just to be able to identify the attachments. Just move this forward. So your gastrocolic attachment and your omental colic attachment are taken down. Slowly, you can either do your advanced bipolar devices or even your monopolar devices. After releasing the superior approach, you can release now the lateral approach, your phrenico-colic attachment and your splenocolic attachment. It's taken down to be able to complete that dissection. And following the line of Tolt, the white line of Tolt, to complete the mobilization. So this is the white line of Tolt. Just following it up. So we do make use of a mixture of energy devices, either monopolar, bipolar, or ultrasonic devices, just to be able to complete our procedure. And then we go for medial dissection. So I'll just cut off the procedure. So that's how we do our superior approach. Then the most difficult one would be the inferomedial approach. You open up your inferior mesenteric vein. So this is now your inferior mesenteric vein. After dissecting and transecting your inferior mesenteric artery, your IMA. So this is now your IMV. After ligation of your IMV, it's clipped and transected. Then you go your dissection towards that lesser sac, identifying and taking care not to injure the pancreas. We all know that once you go up on this line, you'll be able to identify now the inferior part of your pancreas. So opening up, this is now your ligament of Treitz. Now going up and identifying the inferior portion of your pancreas. So this is now your pancreas. So there's a small line that would delineate the plane that you would want to come in. So this is now the superior border of your pancreas, and you would want to open up this one. Once you open up the space, you'll be able to open up and go to the laser sac space. So that's your pancreas. This is the pancreas now. And the inferior border of your stomach. This is now your gastric, greater curvature of your stomach. So opening up. So this is now your stomach. Then you enter the laser sac. This is now the greater curvature. So a completion of the gastrocolic ligament division, you would be able to complete the approach, inferomedial approach in mobilization of your splenic flexure. Then dissection is done superiorly just to complete the dissection of your splenic flexure. So just to show you, then we go laterally, following again the line of thought. So it's just a matter of now of connecting the dots. There's a gauze actually here. So you'll be able to open up and complete the dissection completely. So you just line up that line of thought. Because you were able to do the dissection laterally, inferiorly, then it's just connecting the dots. So once you connect the dot on top, completion of your splenic flexure mobilization is done and completed. So this is now your splenic flexure attachment, phrenico-colic ligament. Now it's just a matter of taking down some small attachments, and the dissection is completed. So this is now the gauze that was placed on top of your pancreas. And dissection is done and completed. So we have a complete splenic flexure mobilization. So a mixture of all the energy devices that's available in your hospital can be done. So I think this one completes the dissection. So in conclusion, the goals for your splenic flexure mobilization is to lengthen the colon, that part of the colon, for a tension-free anastomosis, and the splenic flexure release for distal transverse and proximal colon tumor. And you need to have a good understanding of the anatomical variations, especially the spaces that you would want to get into. There's no gold standard approach on how to do your splenic flexure mobilization. It's always the surgeon's preference. But then again, you would want to have and to know the different approaches just to be able to complete the dissection. And of course, patient characteristics is quite important. Asian patients usually would have a redundant sigmoid colon. And some of this subset of patients, you don't need to do a splenic flexure mobilization. Thank you very much.
Thank you very much, Alan. I think we have just run behind the time. Professor Lee, do we need to add any question or just pass to the next half of the webinar to Professor Craig and Professor Allen for the next chairpersons?
Yes, I think it's better to skip the Q&A because we are behind time about around 20 minutes. So thank you very much.
Thank you.
Thank you. Yes, I think if there's any questions, maybe they could come through the chat and we'll see about answering them as we go. So as we're behind, let's move straight on. So Alan, you've just been talking. I think you are co-moderating this next part of the session with me. The first speaker we have is Professor Yoon Suk Lee from Seoul in Korea.
Yep.
Welcome. Nice to see you. Can you share your screen, and why don't we just start with your talk on rectal mobilization? Thanks.
Okay. Good morning, everyone. First of all, thanks for inviting me. It's my great pleasure to participate in APELS web virtual conference today. My topic is rectal mobilization, transection, and anastomosis tips and tricks. Today, I'd like to emphasize two essential parts. First, effective traction and counter traction for rectal mobilization, and enough tissue compression for safe rectal transection and anastomosis. And last, I'd like to introduce several of my personal tips and tricks for rectal transection and anastomosis. Traditionally, the triangle dissection method, 2 points traction by assistant and 1 point traction, counter traction by operator, and simultaneous dissection by operator had been recommended for meticulous dissection for surgery. This fundamental, the triangle dissection method is also applied in minimally invasive surgery. Also, the laparoscopic rectal mobilization, the traction and counter traction is so important. As you can see in this picture, the 2 traction points by assistant and 1 counter traction point by operator can help surgeon to identify more correct surgical plane. Let me show you my short video clip of rectal mobilization using a triangular method. As you can see in this video, continuous traction and counter traction is so important because actually the surgeon have to know how to let your assistant make a traction, and so also surgeon have to know when, which point the surgeon have to make a counter traction at this area, and that means the traction and counter traction point should be very close to the dissection target. That kind of the triangle dissection method makes surgery less complicated, even if the dissection plan is located narrow and deep pelvis. This is the right side, left side rectum mobilization. As you can see, the surgeon make a traction, try to make a continuous traction around the rectum, and this kind of surgical technique can help surgeon to identify correct surgical plan less complicated. This is a right posterior side, and this is the anterior side too. My assistant make a traction around the anterior part, and my left hand make a counter traction close to the dissection target. This is a posterior part. This is a right lateral side. As you can see here, during the rectal mobilization, making a continuous traction and counter traction is so important. Next. And for safe transection, surgeons have to understand the tissue properties. Actually, the tissue has bypassing nature, the liquid and solid component, and also tissue had intrinsic biomedical properties. That means that all tissue had different type of protein content and different metabolic profiles. And also surgeons have to understand the tissue can be different depending on patient differences, such as anatomical location, underlying comorbidities, medication, pathologic condition, or prior radiotherapy. What is the clinical impact of the difference in tissue properties? Because differences in tissue properties influence tissue thickness and also tissue compressibility. Why it is so important? As you know, the rectal wall thickness ranged from 2 to 2.5 millimeter. Several studies already established that rectal wall thickness. But currently available, the staple height is ranged from 1 to 2.2. The most highest stapler height is around 2 or 2.2 millimeters. But let me think, rectal wall thickness and the currently available staple heights. As I said before, rectal wall thickness is about 2.5 millimeter. but the copular rectal wall is about 5 millimeters. So, but close to stapler height is less than 2.2 millimeters. Actually, it is physically possible to apply a stapler to make safe rectal transection. The answer is tissue compression. Actually, the tissue compression mechanism is different depending on the company. Some company use pre-compression system, and other company use progress compression system. So the surgeon have to know the tissue compression mechanism of their use. But other than the tissue compression mechanism, slow firing is very important, regardless to the tissue compression system. I'd like to show my very short video clip about slow firing for rectal cancer, rectal transection, and why is it, I'd like to emphasize why slow firing is so important. After complete dissection, I apply linear stapler to the lower rectum. And as you can see in this video, I try to perform a slow firing. As you can see here, the tissue between the stapler did not slide away much when surgeon tried to perform a slow firing. Slow firing can guarantee more safe rectal transection. And even if in the very low rectal cancer, we can reduce the number of stapler, especially if surgeons are familiar with a slow firing. So I can say that appropriate tissue compression and slow firing can guarantee better stapler formation and better stapler line integrity and better hemostasis, which is essential part of the safe transection. So to make a safe transection, the surgeon have to understand the tissue properties, and surgeon have to be familiar with why the tissue compression is so important, and slow firing is one of the essential parts to make safe rectal transection. And last, I'd like to introduce several of my personal technical tips and tricks for rectal transection and anastomosis. When I'm making anastomosis, I try to make a stapler a closing point at the center of the rectum. When the tumor is here, and when I try to resect the rectum around this red dot line, if I apply a linear stapler like this, the crossing point is not located at the center part of the rectum, is located to the lateral side. So at this time, I try to introduce a stapler like this and try to make a stapler crossing line at the center of the rectum, especially when I have to use more than 2 staplers for a safe resection. And also, when I make an anastomosis, I try to avoid and remove the stapler closing point line. This video is not actually not mine. I got this surgical video from my colleagues, and that means that when I make a stapler closing line like this way, the surgeon try to make an anastomosis like this, and at this time, when the anvil is not close to the stapler line, and when surgeon make anastomosis like this, the 2 stapler line overlaid. That means that the linear stapler line and circular stapler line can be override, and this kind of anastomosis can increase the risk of anastomosis leak. So usually I recommend to make a staple line at the center of the rectum and try to remove the crossing line like this way. If I introduce anvil at the center, close to the linear stapler line, especially close to the stapler closing line, I can remove the stapler closing line, which is known as most weakest part, and which could increase the risk of anastomotic leakage. So that is my personal preference, and I think it is kind of the one technical tips to prevent anastomotic leakage. And the other, my personal technical tips is I try to remove one dog ear, especially when I use only one stapler for rectal transection, usually in the anterior section. At this time, I try to remove the stapler dog ear one side. Although there is no strong evidence, but there are several studies which reported that most weakest part is dog ear side. The bursting pressure is most lowest compared to the middle part of the staple line. So when I do an anterior section, especially when I just using one stapler for rectal transection, I try to remove one dog ears. This is my take-home message for the safe rectal mobilization, transection, and anastomosis. First, the surgeon have to be familiar with effective traction and counter traction. The surgeon have to know how to let assistant make a traction and how to make effective counter traction to identify more correct surgical plane. The second, the surgeon have to know why enough compression is so important and slow firing is so important for making a safe rectal transection. And third, as I show my several technical, personal technical tips, try to avoid or remove of a stapler closing line or a dog ear. Although there is no strong evidence that this kind of surgical technique can prevent the anastomotic leakage, but personally, I think this kind of the technical tips can reduce the anastomotic leakage after rectal cancer surgery. Thank you.
Thanks, Dr. Lee. That was very good. Next, we have Professor Lee, Professor Suk-Hwan Lee from the Department of Surgery at Kyunghee University, Guangdong, Korea. And Professor Lee is going to talk to us about troubleshooting during laparoscopic surgery.
Thank you very much for the kind introduction, Professor Craig. I'm Suk-Hwan Lee from Kyunghee University. The best way to prevent troubleshooting is not to make any problem before the surgery. I have no disclosure, but I have to disclose one thing. I really hate the COVID-19. These are my contents, but some of the contents are already mentioned by other speakers, so I will skip many of them. First one is the mind patient positioning. Actually, we are doing very stiff Trendelenburg position surgery during our lower rectal cancer surgery. So please don't let the patient down during the surgery. So to do that, patient should be well secured, sometimes well padded, and because we use the gravity for the to make the operative field. Second one is the mind the surgical plane. So one of the principles is the retroperitoneal structure should remain retroperitoneal. So follow the wholly surgical plane, not only in the rectal plane, but also in the mesocolic plane. So usually the lymph node lies in the visceral mesocolon, so you don't have to destroy the retroperitoneal plane. Third one, another one is the, I'm sorry. Yes, another one is the, I try to find the right dissection angle based on the traction and contraction by the assistant and surgeon. So this is the right posterolateral side of the rectum, actually the lateral, right lateral side of the rectum. If you tract and countertract the specimen at the space, you will find the proper dissection plane, as you can see in this slide. So I always tell my resident, try to find the apex of the triangle, as you shown in this slide, like this. Let's move. The second problem we are accounting during the surgery is the redundant sigmoid. This is the paper back to 1914. In this paper, the author have showed as 15 centimeter of a sigmoid. However, he encountered as long as 85 centimeter of sigmoid and sometimes 108 centimeter of sigmoid. This redundant sigmoid makes the surgery more difficult. These are the types of sigmoid colon. Most difficult one is the type D. The sigmoid colon goes up and make an omega-shaped colon. This is the CT scan of my patient. So as you can see in the video, the patient has a very long redundant sigmoid colon. So in this case, I tried to find the reason, because the reason was T1 or T2 reason. So we cannot find that properly during the surgery. However, look at this. The sigmoid colon goes up like this and goes down on the 5 o'clock position and then goes up again. So for the time, I will skip the video. Please excuse my poor drawing. So one of the problem of the long redundant sigmoid is there is a chance of the marginal artery injury during the dissection. If you dissect mesentery very much during the medial dissection, there are a lot of increased possibility of damaging the marginal artery, as shown in this slide. So this is the short sigmoid colon. We have a lot of room from here to here. However, when the sigmoid getting redundant, there is a high possibility of damaging the marginal artery here. So if you damage marginal artery over here, you have to cut the bowel over here, and then you need another manipulation such as a spring flexion mobilization. The third one is the adhesion. So if you encounter the adhesion like this, so don't hesitate and then try to find the fusion plane like this. And then always think about the ergonomics of the laparoscopic surgery. So please do not hesitate to move over to the opposite side of the patient while you are performing the adhesiolysis like this. For the time, I will skip the video. So the most important principle of the laparoscopic surgery is align with the target organ. So surgeon's gaze should be straight from the target organ and the screen, the monitor. So straight gaze is more efficient in dissection. So don't hesitate, move to the opposite side of patient, avoid mirror image, and then first of all, place the trocar away from the previous scar to do the adhesiolysis. So another one is the careful dissection. And one of the most frequent problem we are facing is the bleeding during the surgery. This is the right hemicolectomy around the mid-colic artery. So to control the bleeding, I place the hemorrhag here, but sometimes the hemorrhag does not work very well like this. And then we find the bleeding. In this case, don't be panic. Don't be panic and try to find the breathing focus, and then don't take too much time, but take some time to find the exact breathing point like this. And then if you identify the breathing point, we have a lot of tools to control breathing recently. So press the hemorrhage once again, or sometimes press the ligature instrument, or something like that, as shown in this slide, this video. I firstly introduced the hemorrhage, but breathing won't stop. And then later on, I press the ligature, and then with the advanced energy technology, you can control the breathing like this. Let's move. So in cases of breathing, first thing is the don't be panic. We have many armamentarium to control breathing, such as the harmonic scalpel, ligature, hemorrhage, and so on. So do not coagulate before you are sure about it. So I always tell to my resident, if you are using the hook instrument to dissect, you have to hook first and then look second, and then if you have confirmed, then cook. After you control the breathing, clean the mess for the dissection. What about the ureter? In this case, the patient had a very huge tumor around the right side of the ureter, and then preoperative CT scan showed the right ureteral invasion. So during the dissection, you have to cut ureter, as shown in this video. So to prevent the unexpected, uneventful, unrecognized ureteral injury during the surgery, please place the ureteral catheter before the operation. And then in this case, you can identify the ureteral catheter, and then you just perform the primary anastomosis of the ureter as shown in this slide. So this is a very tedious work to suture the cutted ureter, but if you are following the principle of surgery, the suturing the structure, it can be controlled very safely. Next one is the minor anastomosis. You always think about the blood supply of the mesenteric side and anti-mesenteric side. So please place the clamp or the stapler line about 30-degree angle as shown in this slide. So it will preserve the blood supply of the anti-mesenteric border. After performing the transection, before you anastomose, please check the color of the end. As you can see in this slide, the purple color of the end of the anastomosis, the anvil line, is not good. So in this case, you should cut again and place the anvil with a healthy tissue like this. So in conclusion, this is a take-home message. Prevention is better than troubleshooting. So to do that, you have to stick to the basic and then select a good risk patient if you can. But in general, we cannot select a patient. Thank you very much for your kind attention and time.
Thank you, Sukhan. So we'll go to the next lecture, which will be given by a very good friend of ours. He's an associate professor at the Division of General Surgery at the Department of Faculty of Medicine, Siriraj Hospital, Mahidol University in Bangkok, Thailand. He's also the Deputy Chairman of the Department of Surgery of the same institution. He's also a board member of the Asia Pacific Endo-Lap Surgery Group and a very famous surgeon in Thailand. Please welcome my very good friend, Professor Vitoon Chinswangwatanakul. Vitoon?
Thank you very much, Alan. Right? I declare nothing for my conflict of interest. Actually, when we talk about the robotic surgery, I would like to thank Professor Dr. Tung, who demonstrated and compare the result of robotic surgery and laparoscopic surgery at the beginning. Right, very clear and very extensive review as well. Robot assist laparoscopic surgery actually is one of the new challenge for the last 2 decades, especially after the millennium. And as you can see there, after 2000, the year 2000, the US FDA have already approved several procedures, including the colorectal surgery procedure. When we look at the platform, the famous platform of the robotic surgery at the moment would be the Da Vinci surgical system that consisted of 5 key elements. Firstly, the ergonomic design. So surgeon can sit down and do the operation at the console. They can also teach the trainee at the same time if you have 2 consoles in your department. The patient side card is very stable, and also the interactive robotic arms that moving very intuitive response. And most of all, the 3-dimensional high-definition stereoscopic vision will provide you a very stable feel of the operation. And the secret of the successful, probably the endorist, that would be give us a very flexible movement with the 6 degrees of freedom when compared to the conventional laparoscopic surgery that we use our instrument like a chopstick procedure. So this will help surgeon a lot to do precise surgery. We can move with the enhanced dexterity because it's a very stable platform. It also economic comfort for surgeon. So with this equipment, we can do the complex dissection and reconstruction that very important in colorectal surgery. So far, the Da Vinci platform have developed up to 4th generation. The most key component is the complex multi-quadrant platform that you can move around the whole intra-abdominal any quadrant freely. So when you look at this video, you will see on the left-hand side is the robot platform, very stable. And on the right-hand side is a conventional laparoscopic field. Sometimes you need to make agreement with your assistant, the camera holder. So with this stable platform and a very clear visualization, make you more comfortable to do the operation, especially in the very, very deep pelvic cavity. Sorry. With this platform, we can do the general tissue manipulation, as you can see on this slide, on this clip. So you can manipulate the tissue with meticulous gripping of your finger as well. And the robotic surgical platform combine this kind of the whole characteristic that can cause very comfortable to do intraoperative abdominal surgery, such as dissection and control of the blood vessels, the mobilization and bowel dissection, especially in the deep pelvic cavity. Let's show you the short video clip here that have been edited by one of my junior staff, Dr. Tharathon. Basically, I will do the 5-port by spreading you can see here, the trocar ports on both sides of the abdomen using the camera at the center close to the umbilicus, as you can see here. For the low anterior resection, I start with the dissection or mobilization of the rectal sigmoid colon. I actually personally do not stick on whatever medial to lateral or lateral to medial approach, as far as I can do it easy and can demonstrate the ureter or location of the ureter safely. And you can see here the very stable platform. I can use only the diathermy. Normally, I will dissect with the hook because it's very easy to control, traction and tension, because you will have the two arms on the right side. One hold the tissue stable, and another one you just move it. And after we dissect and find the IMA, I personally prefer to sever cut the IMA with the staple, vascular staple like that. And a very easy way to handle the rectal stump, the rectal mobilization, I use the cord tape to make sure we can handle the tissue safely. Otherwise, if you use the grasper alone, sometimes you can injure the tissue very easy because the grip of the robot is very strong. And you can see here, we can use the diathermy to mobilize and dissect the perirectal tissue deep down to the pelvic floor until you see the pelvic diaphragm like that. This patient had a tumor very low, about 5 centimeters above the anal verge. So we can mobilize very, very precise and very close to the pelvic floor like this. Right, this is a seminal vessel, as you can see here, with a safe tension and traction by your own and a bit from your assistant. You can freely mobilize the rectum downward to the area, and because it's very low one, I asked my assistant to do rectal examination to localize the position of the tumor safely, and then we do a resection and anastomosis as usual. Sorry. Right. So if we look at the evidence-based surgery, comparing the robot, laparoscopic, and open colorectal surgery, basically the concerning issue between these three kinds of procedure, probably the quality of TME excision or the rate of circumferential margin, as Dr. Tung already mentioned at the beginning. We also concerned about the oncologic outcomes, nerve and urogenital function preservation. That is I think very much beneficial from doing with the robot surgery. And operative time and cost certainly is an issue that we need not to do any study, because the cost more expensive, and at the same time, due to the new technique, the operative time also a half or 1 hour longer than laparoscopic conventional. And what we need to demonstrate to compare these three procedures is a short-term and long-term operative, post-operative outcome. So when we look at the literature before 2010, probably quite early, some literature do not show any advantage of robotic surgery at all. But we look at the literature after 2010, perhaps at the middle decade of the last decade, you will see that the conventional laparoscopic, when compared to the robotic surgery, the robotic surgery show the significantly fewer conversion rate, because they can do probably more successful sphincter saving procedure due to the precise instruments of the robot. And when we look at the recovery, and especially for the voiding and sexual function is like the urological field that the robot total prostatectomy is very popular because they can save the voiding and sexual function. So very important for every man as well. And several literature also demonstrate that the robotic surgery could get the earlier recovery of normal voiding and also sexual function as well in the laparoscopic colorectal surgery. When we look at the measurement of pathologic adequacy and also the oncologic outcome, several literature also satisfy with the outcome. At least they do not inferior to the laparoscopic and open surgery. And the short-term outcome seem to be one of the most benefit when compared the robotic surgery with the laparoscopic surgery. The robot can get less blood loss, can get a shorter post-operative hospital stay. They also have the lower rate of biliary retention, lower post-operative complications such as surgical site infection, and also lower anastomotic leakage. And when we look at the long-term outcome comparing laparoscopic and robotic surgery and also the open surgery, there were no significant differences in 3 to 5 year survival outcomes and also local recurrence among these 3 procedures, as you can see from several papers. When we look at the ROLA trial, that is very much disappoint a lot of robotic colorectal surgeons. I think that is probably because the trial just started in 2009 and up to 2015. At that time, I think most of the robotic surgeons for colorectal surgery still be not get enough experience. And this paper also enroll a lot of centers, up to 29 centers in 10 countries, that make a lot more difficult to make the surgeons to be sure that the surgeon will have the similar experience. Anyhow, the ROLA trial do not convince the conversion rate in robotic surgery when compared to the laparoscopic surgery. In some subgroup like obese patient, the robot may get more benefit, especially for the patient with a narrow male pelvis. So in conclusion, Mr. Chairman, ladies and gentlemen, the robotic surgery, especially for colorectal surgery, is still the early stage and may need more evidence-based support. The current studies regarding the use of robot surgery in GI cancer reported unsettled consensus. The development of surgical technique, especially for the latest model like Da Vinci Xi, as well as the future platform from many companies, may encourage the robotic surgery applicable for colorectal surgeons in their future. So many studies still demonstrated feasibility and benefit tendency. And exactly the cost effectiveness need to be carefully judged. I still believe that robotic surgery is the future of colorectal surgeons. Thank you for your attention.
Thank you, Vitoon, for a very nice lecture. For the next lecture, our lecture will be talking about diagnostic and therapeutic colonoscopy. Will be given by Assistant Professor Chainarong Phalanusitthepha from Thailand. He works with Professor Vitoon also in Siriraj, Mahidol University. Chainarong?
Hi. Now, can you see my slide, please?
Not yet, Chainarong.
Okay.
There you are. You can see it now.
Okay. Now, thank you very much for a kind of introduction. My name is Chainarong from Sirat Hospital. Today we'll talk about the diagnosis and therapeutic colonoscopy. This slide is always seen in the screening colonoscopy. And how do we precise diagnosis and how to make a proper treatment? We have a technique that we will share about. Everyone knows about the adenoma and carcinoma sequence, which if we leave polyps for a while, maybe it's grow to be a cancer. And if this study show that in every colonoscopy, we can leave the polyps, which may be missed polyp or incomplete resection. These papers report that the mean incomplete resection rate is about 14%. One of the most popular technique for the diagnosis is chromoendoscopy. Nowadays, we develop for the image enhancing endoscopy, and this GNS classification is the standard of the optical endoscopy, optical image endoscopy. If we found the polyps and we analyze with the GNS classification, we will see we will divide in class 1, class 2A, 2B, and 3. The class 1 is hyperplastic polyps, which we can follow up and do not require any endoscopy. For 2A and 2B is mean adenoma or early colorectal cancer. It means mucosal cancer, which this can treat with the endoscopic treatment. Then we have to diagnose very precisely because of we have to treat properly to get rid of them. And class 3 is advanced cancers which need surgery. We have 2 guidelines recently, ESG guideline in 2017 and USMSTF in 2020. Both guidelines quite the same. If we have diminutive polyp which less than 5 millimeter or the small polyp is 6 to 10 millimeters, this guideline recommend the cold snare polypectomy. The other is pedunculate polyps, we need EMR. The last size polyp less than between 10 and 20 millimeters, maybe EMR, and more than 20 millimeters, we have to consider about the EMR or some recommend piecemeal EMR, which we will talk later. If more than that, more than 20 millimeter, maybe we have to consider about the ESD. First, we will focus the very small polyps. Most of endoscopists always get rid of the small polyp, which we use the forceps, which the width of the forceps is 256 centimeter, and those who use the jumbo polyps is 0.8 millimeters. Like this video show the cold snare polypectomy, which nowadays we promote to use this because of the no need electrosurgery, which they may be injury the tissue. This paper show that if we found the polyp which less than 50 millimeter, most of the endoscopists, this paper survey in the Southeast Asia, and most of them, 28.6% use the forceps. But the data show that if you use the forceps, maybe you have incomplete resection rate up to 10%, compared to the snare polypectomy is 4.4% only. So we recommend that we have to use the snare polypectomy. If we use this study compare about the jumbo forceps is the big forceps, the width of the forceps is 0.8 compared to the snare polypectomy, show that is like the same of the completely moving polyps. So if you see the small polyp less than 5 millimeter, please use jumbo forceps or snare polypectomy. That recommend in both guidelines. For the polyps larger than that, it's always we always seen this polyp is less than 10 millimeters. When we found that we have to diagnose like this, we use NBI to diagnose it, and this is nice 2A and snare. We can use both hot snare and cold snare. Which hot snare is the we apply the electrical current, but cold snare is not. The complete resection, when we compare hot and cold snare, we show that it's quite the same. Both technique can complete resection, but this is also another study and show the same. For the residual rate of the snare polypectomy, as these two papers show that after 3 weeks, we found only about 1% of residual adenoma. And if we gonna go for 1 year, we maybe found 2.5% of residual adenoma, which is very low. But if you use the hot snare polypectomy, there's a lot of burning around, which damage tissue, both submucosal tissue and the thickness of the colon compared to the cold polypectomy. If we found the polyps which than 1 centimeter, that the both guidelines recommend EMR. EMR is like we inject the saline into the submucosal plane and then snare it. This because of we have to beware of the perforation. And this is the technique of piecemeal EMR because of the maybe sometimes we found a large polyps like this and we cannot snare it in one time. So we have to snare little by little until it get out. But this technique maybe is not so good because of they have a residual or recurrent adenoma about 35% after follow-up. But it's more easy and a very good technique for sometime when we found the polyp in very difficult area. And this also show that the recurrent rate, if we found the polyps less than centimeters and more than 2 centimeters, as you see the recurrent rate about the small polyp is less than the big polyp. For the PISMU-MR also, in the PISMU-MR, we found that maybe we have a positive margin more than the normal EMR. This is the same. As you see, the PISMU-MR have a recurrent rate more than the conventional one. One technique is very good and recommend for use in the large polyp. We call that underwater EMR, which we fill the saline inside the lumen, and then we grab it as a normal EMR. The water will enlarge the endoluminal tissue cavity, so that when the colon is not tense, the polyp will look smaller and we can grab it in one time. The polyp recurrence and incomplete resection is smaller than conventional EMR. And this is my last slide. After we do the polypectomy, maybe there's a various recommendation for the follow-up. If we have only 1 or 2 small tubular adenoma, maybe we surveillance as a 5 or 10 years, but it's more than that, maybe 3 years. But if we have a lot of adenoma, more than 10, maybe we have to consider about the early colonoscopy. But if you do the PISMU-MR, maybe you have to look after that within 3 to 6 months. That's all of my talk. Thank you very much.
Thank you, Professor Chainarong, for a very extensive lecture. Now we go to the last lecture for this morning's session. The next lecture will be about hybrid endolaparoscopic colorectal surgery. Will be given by Professor Simon Ng. He's an Associate Dean for Student Affairs at the Faculty of Medicine from the Chinese University of Hong Kong. He's a professor and the Chief of Division of the Colorectal Surgery Department of Surgery of the same institution. He's an honorary consultant of the Department of Surgery, Prince of Wales Hospital in Hong Kong, also a board member of the Asia Pacific Surgery Group. Please welcome our very good friend, Professor Simon Ng. Simon?
Thank you very much, Alan, for your very kind introduction. Now, because of time, I think it's I'll try to cut my lecture short, and it's a kind of a wrap up for today's program, because you know the whole thing is about learning Endo-Lap, and the very first lecture was given by Professor Michael Lee is on Endo-Lap OR, and now I'm going to talk about hybrid Endo-Lap colorectal surgery. I have no disclosures. Now, both endoscopy and laparoscopy are essential components of our colorectal surgery practice, but each modality has its own limitation. Now, for endoscopy, it can only be applied endoluminally, only amenable to superficial lesions, very limited hemostasis, limited or no suturing, and restricted maximum lesion size that can be dealt with. Whereas for laparoscopy, it has imprecise localization for endoluminal lesions, because the instruments are straight, so there was a reduced in degree of freedoms. And of course, after anastomosis, I think laparoscopy actually could not evaluate the suture line inside the lumen. But by combining both techniques, basically all these limitations can be overcome, so that both modalities actually are complementary to each other. Now, this is the concept of hybrid endo-lap surgery. Now, in the very first lecture, Professor Lee already mentioned that, you know, the endo-lap OR setup is crucial for doing endo-lap surgery. And he also mentioned that with the endo-lap OR, the efficiency actually can be improved. And because the turnover time for doing endoscopy inside the OR would be much quicker. Now, what are the applications of hybrid endo-lap in colorectal surgery? All right, so these are the kind of applications, including intraop endoscopy during lap colorectal surgery, hybrid endo-lap surgery for large colonic polyps, and even using hybrid endo-lap repair of rectal anastomotic leak, hybrid nose colectomy, and TATME. So the last three actually are extended concept of endo-lap surgery. So the most common application indications of doing endo-lap surgery, it's basically intraoperatively intra-op endoscopy during lap colorectal surgery. Now, it actually allows us to perform intra-op localization of small lesions. It allows us to remove synchronous polyps if those were not removed before the surgery. It allows endoluminal visualization of tumor margin to determine the level of bowel transection. And finally, it's for evaluation of rectal anastomosis. So, in fact, the most common, indication when we use intra-op endoscopy is basically for evaluation of rectal anastomosis, because the endo-lap OR setup actually allows intra-op colonoscopy to be done immediately after lap rectal anastomosis. Now, on-table colonoscopy actually serves three purposes. One is it can do an alley test to make sure that the anastomosis is intact. Second is like shown in this video clip, you can check for any bleeding from the state hemostasis. To take down the anastomosis and redo it. Now, in fact, from Cleveland Clinic, there's a study trying to compare, routine intraoperative endoscopy versus selective intraop endoscopy after doing a rectal anastomosis. So this study actually found that if you perform a routine intraop endoscopy, the total postoperative anastomotic complications in terms of leak and also bleeding, which are very much reduced when compared with those undergoing selective intraop endoscopy. So it really helps. So another application, you have listened to the previous talk about large colonic polyps. So it's quite common nowadays to encounter large polyps because we're doing more screening and with also advances in endoscopic technology. But if you encounter something like this big, lateral spine tumor, usually this is your reaction. Usually you surrender. All right. So in the past, either you can subject your patient to laparoscopic colectomy, a radical colectomy. But laparoscopic surgery colectomy has a morbidity. And basically, you're over-treating these lesions because many of them are actually benign. Of course, you can consider doing a ESD, all right, if you have the expertise. But first, you may not have that expertise. And second is, ESD has also got complications, all right, such as perforation and bleeding. So do we have something in between? So now hybrid endo-lap surgery actually comes in. Now, one of the indications of doing hybrid endo-lap is for large colonic polyps, like what I've shown you in the previous picture, or polyps in unfavorable location. Now, if you look at the literature, people will have, different terms for this kind of surgery, like, the most commonly coined term would be combined endolaparoscopic surgery or cells. Now, there are actually two ways of doing this hybrid endo-lap for colonic polyps. One is by doing what we call laparoscopic assisted endoscopic resection, or secondly is endoscopic assisted laparoscopic wedge resection. All right. So this is a picture diagram showing you how the first one, the laparoscopic assisted endoscopic resection, actually works. So patient underwent the colonoscopy in the OR, all right, GA doing laparoscopy at the same time. So during colonoscopy, you will find this polyp of this size. And then you can apply laparoscopy because laparoscopy actually can help perform adhesolysis. Also facilitate bowel mobilization, and also you can manipulate the bowel to place it in a location which is more favorable for you to do the endoscopic resection. So it helps a lot. All right. So with that laparoscopic guidance, you can safely resect the polyp endoscopically. And if you are resecting too deep, resulting in risk of perforation, no worry, because with the laparoscopy at the same time, you can suture repair the serosa, all right, to minimize the risk of perforation. So this is the concept of doing laparoscopic assisted endoscopic resection. And then another way of doing this is endoscopic assisted wedge resection. So like this. So for first, under endoscopic guidance, you're visualizing the luminal field. You can apply laparoscopic stitches around the lesion to hitch it up like this. And then you can perform stapling. All right, use laparoscopic stapling to resect the polyp together with that bowel wall under endoscopic guidance. All right, so this is the end result. So this is endoscopic assisted wedge resection, another way of dealing hybrid lap endo-lap method to deal with these large polyps. So in fact, there is a systematic review of 18 cell studies with over 500 patients. So they're trying to look at the performance of this approach to treat colorectal polyps. So the successful endoscopic resection rate ranged from 58% to 100%. Conversion to open surgery was required in less than 5%. Complication ranged from 0 to 18%, but there was a shorter operation time and length of stay when compared with a formal laparoscopic colectomy. So we do see some benefits of using this approach in treating large polyps. The last is I would like to talk about this extended concept of hybrid endo-lap surgery with transanal endoscopic platforms such as the TEM, TEO, or TAMIS, right? All these transanal endoscopic platforms actually can allow surgeon to perform something like a single port or laparoscopic surgery within the rectal lumen. So this is also considered as a kind of, a hybrid endo-lap surgery. And with the presence of these platforms, it actually opens up more possibilities. And also, it's also kind of like a NOC surgery, all right? So one application of this hybrid endo-lap approach using a transanal platform is the management of anastomotic leak. Now, traditionally, if you need to manage patients with leak, usually will be a laparotomy. You take down the anastomosis and do a Hartmann's procedure. But with this endo-lap setup, basically the surgeon can perform a laparoscopy first to look at the, to examine the intraperitoneal cavity, to do a adhesolysis, you do a lavage, and use that to fashion a stoma. And at the same time, you can perform an endoluminal approach using a TEO, for example, putting a TEO device in the anal canal and then directly visualize a perforated site and do an endoluminal suture repair. So this is endo-lap, management of a rectal anastomotic leak. So it's reported by William Chen, also one of our board members of APELS. So in this study, he has attempted this approach in 16 patients, all right? And at the end, 3 requires a conversion, and then a successful hybrid technique was done on 13 patients, and all patients actually has the leak healed primarily. And for the converted patients, at the end, 1 also healed primarily. So no patient actually required further intervention. And at a follow-up of 1 year, actually, there was no anastomotic sinus or fistula formation. And this is another way of using this hybrid endo-lap approach. It's this NOX colectomy. Basically, it implies laparoscopic colectomy, in particular lap colectomy, without a mini laparotomy wound. Because for this approach, the surgeon actually makes use of a TEO device, put it in the anal canal. So after you have transected the rectal stump, you put the TEO device into the peritoneal cavity, and then basically you grab on the specimen and retrieve the specimen transanally with the guard of the TEO device, all right? So it can save you from having an incisional wound. So this approach was actually first reported by the late Hester Jung, all right, our very good friend. And it's a short clip. This is operator was Professor Lee, so I think it's a formal, laparoscopic lap hemicolectomy, mobilization, pedicle division, and so yeah, pedicle division. So yeah, this is the TEO device. So after cleansing of the anal canal, all right, so you can see the surgeon when everything is ready, they rectum like this, and then insert the transanal surgeon actually inserted the TEO device like this, and then extracted the specimen transanally. All right, now first, obviously they need to prepare for the anastomosis. So the transanal surgeon will put in the anfill, all right, first. So this is for the preparation of the anastomosis. I'll put the anfill into the proximal colon, and because of time, I think I'll just speed up. So this is the, basically this is the specimen retrieval transanally like this. And then they'll complete the anastomosis in the usual fashion. All right, because of time, I better skip this. And they have actually conducted a randomized control trial. All right, and 70 patients were randomized, 35 using this hybrid NOX approach, and then 35 using the conventional approach. And what they found was that using those patients who received a hybrid approach actually has significantly lower post-op pain, and there was also lower wound infection rate in the hybrid group. And also, I think they have also done a long-term analysis on the oncologic outcomes. Basically, the hybrid NOACs approach did not jeopardize survival. And of course, other hybrid NOACs, Endo-Lap hybrid Endo-Lap approach would be this TATME. It's in essence also a hybrid NOACs proctectomy. All right. And basically, I have no intention to talk anything more about TATME because of time and also because this is not within our agenda. But mind you, this is also another application of hybrid Endo-Lap, all right, but it's for proctectomy. So this is Masaki Ito, all right? So conclusion, all right? So you can see that by combining endoscopy and laparoscopy, it's beneficial in different indications to reduce invasiveness and also increase efficiency and safety of therapy. And the respective contribution of both modalities to intervention actually varies, all right, ranging from simple endoscopic support, such as for localization of lesion, to a full-scale hybrid NOACs procedures, all right? So that's why it's very important to learn both endoscopy and laparoscopy, all right, as a colorectal surgeon. And this is exactly the mission of APELS, all right, is to deliver this training and learning for our trainees, all right, and learning endo and also laparoscopic skills. So with that, I think I would like to end my talk. Thank you very much.